You know, usually when we talk about a medical diagnosis, there is this underlying expectation of, well, precision.
Oh, absolutely.
Yeah, it's supposed to feel like engineering, right? You break your arm, the x-ray shows that jagged white line, and the doctor just points at the film and says, there it is.
It's broken.
Exactly. It's broken. We cast it. You go home. It's clean. It's binary. And honestly, it's incredibly comforting because the problem is entirely localized.
It is comforting. I mean, the entire modern medical apparatus was essentially built on that acute care model. You identify the pathogen or the fracture or the tumor, you isolate it, and you target it. We are highly conditioned to expect a localized, visible enemy.
But then you step into the world of neurodevelopment or trauma or complex mental health conditions, and suddenly that x-ray machine is just, well, it's entirely useless. We are looking at a diagnostic landscape that is murky, to put it mildly.
Murky is a good word for it, yeah.
Which brings us to what we are doing today. Welcome to the deep dive, everyone. We aren't looking at a textbook today or a brain scan. We're looking at something arguably much more revealing about how a society actually processes that diagnostic murkiness.
Right. We're looking at a digital front door.
Yeah, exactly. We are analyzing a primary source that acts as the digital front door to a massive healthcare system.
3 specific screenshots, to be exact.
Right. 3 screenshots from a website called Psychiatriguiden, which translates to the Psychiatryguiden. And this is operated by the capital region of Denmark.
Right. Officially, it's Region Hovedstaden Psychiatry.
Yeah. So if you're listening, think of this as the main centralized portal for anyone seeking mental health resources, triage, or treatment in and around Copenhagen. Our mission today is to completely deconstruct this digital menu.
Because it's not just a menu, is it?
No, not at all. I have this theory that you can tell a lot about how society views mental health, not just by how they treat it in the clinic, but by how they organize the digital architecture that gets the patient into the clinic in the first place.
It's the triage architecture. A navigation menu on a regional health portal isn't just a random list of links. I mean, it is a highly curated blueprint that reveals the underlying philosophy of patient care.
Right.
It shows us their stance on patient autonomy, how they handle the messy realities of comorbidity, and what they fundamentally believe the relationship between a citizen and the medical establishment should be.
And looking at these screenshots, what's immediately apparent is that this architecture is sitting on a major, almost structural fault line in modern psychiatry.
A huge fault line.
Yeah, meaning what exactly? What's the core tension here?
Well, the tension is between the diagnostic categories we've used for decades and the clinical reality that those categories are, well, they're starting to fall apart.
Okay, that sounds dramatic.
It kind of is.
Yeah.
If you look closely at this menu, you can see a system that is still rigidly clinging to the ICD-10. That's the older international classification of diseases.
Right, the 10th edition.
Yeah, and they're doing this while bracing for the reality of the ICD-11, which fundamentally changes how we categorize mental illness. And the striking thing here is the missing ICD-11 implementation.
The missing ICD-11. Okay, let's get right into that then. Looking at the first major section of our source material, we see what looks like the standard standalone psychiatric categories. They're neatly laid out in these little green and white boxes.
Yeah, the classic roster.
Right. We have ADHD, angst, which is anxiety, autism, bipolar disorder, depression, OCD, PTSD, and personality disorders.
If you walked into literally any psychiatric ward in the Western world, these are the heavy hitters. These are the diagnoses that, under the old ICD-10 models, had very established, rigid clinical criteria.
Like checking boxes on a clipboard.
Exactly. You had to meet, say, 5 out of 9 criteria to get the label. But this is where that missing ICD-11 context becomes so fascinating.
How so?
Well, look at the category for personality disorders on this Danish portal. Under the old system, if you had a personality disorder, you were put into a specific box. You were borderline, or you were narcissistic, or you were avoidant. It was strictly categorical.
Wow, you got a one-word label.
Yeah, but the World Health Organization released the ICD-11, and Denmark is actively transitioning to it. And the ICD-11 essentially nukes those specific personality disorder categories.
Wait, really? They just got rid of borderline personality disorder?
Essentially, yes. The new model in ICD-11 is dimensional, not categorical. The clinical consensus realized that human brains just don't fit into those discrete boxes.
That makes sense. Brains are messy.
Very messy. So instead, ICD-11 assesses the overall severity of personality dysfunction like, is it mild, moderate, severe, and then lists prominent traits like negative affectivity or detachment or disinhibition.
Wow. But that sounds vastly more complicated to explain to a patient.
It is. And that is the massive challenge facing portals like Psychiatriguiden. That's why the ICD-11 is glaringly missing from this front-facing menu.
Because it's a UI nightmare.
Exactly. How do you design a navigation menu for the general public that is used to the old categorical labels, when the clinical reality behind the scenes is moving toward a highly nuanced, spectrum-based dimensional model?
If you change the website tomorrow to say severe personality dysfunction with prominent negative affectivity, nobody's going to know what to click.
Right. They'd be totally lost. So the website is functioning as a translation layer. It's keeping the old, familiar ICD-10 labels on the front end to get people in the door, even if the doctors on the back end are starting to look at the diagnostic criteria completely differently.
That is so interesting. Okay, but I'm actually less interested in the labels themselves and more interested in what is written directly underneath every single one of those main headings.
The subtext.
Yeah, because there is a recurring pattern here. Almost every single one of these major categories has the exact same triad of links beneath it.
It's very consistent.
It is. Under ADHD, under anxiety, under depression, it always says three things. First, Weiden which is knowledge about. Second, behandling of, meaning treatment of. And third, Cursor, rådgivning og mer Weiden which translates to courses, counseling, and more knowledge about.
Knowledge, treatment, courses. That specific sequence is very deliberate.
It feels exactly like the onboarding process at a highly complex corporate job. You know, you don't just get thrown straight onto the factory floor on day one.
Right, you'd be a liability.
Exactly. First, you get the company handbook. That's the knowledge phase. Then you actually do the work, the treatment phase. Then you have ongoing professional development, the courses.
It's a great analogy.
But my question to you is that actually a good thing in a medical crisis? I mean, if I am suffering from severe panic attacks or severe depression, I don't want a handbook.
You want relief.
Yes.
Yeah.
I want a doctor to fix it right then and there. Does the system run the risk of putting way too much homework on the patient before they actually get help?
That is the natural critique. Absolutely. It feels like adding friction to the process. But neurologically and clinically, that homework is actually the very first phase of the treatment itself. We call it psychoeducation.
Psychoeducation. But how does reading an article about anxiety actually stop a panic attack?
It comes down to top-down regulation in the brain. When a patient's experiencing a panic attack or a severe PTSD flashback, their amygdala, which is the fear center of the brain, is essentially hijacking the entire system.
It's just sounding a massive alarm.
Exactly. The body floods with cortisol and adrenaline. The patient literally feels like they're dying. We're going crazy. The traditional, older paternalistic medical model would be to just hand them a benzodiazepine to chemically force the nervous system to shut down.
Which works, right?
Well, it works in the short term, yeah. But it doesn't teach the brain anything, and it carries massive risks of dependency. Psychoeducation, that knowledge about link plays so prominently before treatment, actually engages the prefrontal cortex.
The logical part of the brain.
Right. When a patient learns the actual biological mechanism of their panic attack, when they learn that their heart rate is spiking because of an evolutionary fight-or-flight misfire, they can begin to intellectualize that physical sensation.
Wait, so the physical act of learning about the brain actually changes the brain's reaction to the trauma?
Precisely. Engaging the prefrontal cortex to learn a concept actively inhibits the amygdala. It acts as the biological tether. It takes away the secondary fear, which is the fear of the fear itself.
Oh, wow. So the feeling shifts from I am dying to my nervous system is currently misfiring in a well-documented way, and here are the mechanics of it?
Yes, that is exactly why this Danish portal places knowledge as the very first gateway. The system fundamentally assumes that an empowered, educated patient has much better clinical outcomes than a passive one.
Okay, that makes a complete biological sense. But what about the third part of the triad? The cursor, or courses. Why offer a course on bipolar disorder or depression?
What's wrong with a course?
Well, a course sounds like I'm learning Microsoft Excel, not managing a potentially fatal mood disorder. Why not just say therapy?
Because a course fundamentally shifts the power dynamic and the social context of the illness. Individual therapy is vital, but it is still fundamentally isolating. It's just you and a clinician in a closed room.
Right.
A course, on the other hand, implies a curriculum. It implies a shared learning environment, and most importantly, it implies chronicity.
Chronicity meaning you're going to have this for a while, so you better learn how to manage it.
Exactly. You don't take a course to cure a broken arm. You take a course to learn how to manage diabetes, or in this case, bipolar disorder. It teaches sleep hygiene, trigger management, and emotional regulation.
And doing that in a group helps.
Biologically, yes. Doing this in a group setting with other people, navigating the exact same diagnosis, leverages our profound human need for social normalization.
Oh, I see.
When a patient sees 10 other competent, everyday people sitting in a classroom learning how to manage their ADHD or OCD, it physically reduces the allostatic load, which is the chronic wear and tear of stress and stigma on the body.
It destigmatizes it right there in the UI. It treats mental health management as an educational pursuit rather than a shameful secret.
Exactly. And you actually see that tension we talked about earlier, the old categories versus the messy reality, starting to bleed out into the menu when we look past those single-word diagnoses.
Which brings us perfectly to the next tier of the menu, where things get significantly messier. We are looking at conditions that break that neat little one-word mold entirely.
The complex cases.
Yeah. Specifically, two groupings stand out. The first is schizophrenia, schizotypie og andre psychosedelstand, meaning schizophrenia, schizotypie, and other psychotic states. And the second is doppelt diagnose, which translates to dual diagnosis, mental illness, and substance use.
These two categories are the clinical reality of the dimensional model breaking right through the rigid website design. Even without the full ICD-11 implemented, they have to acknowledge the blurriness here.
Let's look at the psychosis one first. Okay, let's unpack this. Why group schizophrenia, schizotypie, and other psychotic states all together under one umbrella?
It seems clunky, right?
It does. If I have depression, I click depression. If I have ADHD, I click ADHD. Why doesn't schizophrenia get its own standalone page?
Because psychosis is one of the most notoriously fluid and terrifying experiences a human brain can undergo, and it rarely presents in a neat textbook manner upon first onset.
Okay.
Let's look at the underlying mechanics. Psychosis, which includes hallucinations, delusions, disorganized thinking, is generally linked to massive dysregulation of dopamine pathways in the brain, specifically in the mesolimbic system.
So too much dopamine.
Too much dopamine signaling in certain areas, yeah. And that leads the brain to assign profound significance to completely irrelevant stimuli.
So a random shadow on the wall isn't just a shadow. The brain is biochemically sourced to perceive it as a threat or a deeply important sign.
Precisely. Now, historically, psychiatry was obsessed with figuring out exactly which box that dopamine dysregulation fit into. If it lasted 6 months and had specific negative symptoms, it was schizophrenia.
And if it didn't?
If it featured severe paranoia and eccentric behavior, but no full-blown hallucinations, well, then it was schizotypy. If it was drug-induced, it was something else entirely.
But to a patient experiencing it, or a mother watching her son experience it, they don't know any of that criteria. They just know reality is fundamentally breaking down.
Exactly. If a patient is in the early stages of a psychotic break, their cognitive resources are massively depleted, forcing them to navigate a digital menu that requires them to self-diagnose the specific clinical flavor of their reality distortion. Is not just bad design, it's clinically dangerous.
So they just lump it all together.
By creating a unified category, the psychotic spectrum, the system gathers all the resources into one accessible hub. It says, if you or your loved one are experiencing a break from reality, just start here. We will figure out the specific label later.
It reduces the cognitive load at a time when the patient's cognition is actively under attack by their own brain. That makes total sense.
It's pure triage.
Okay, now let's pivot to the second complex category. Dual diagnosis, mental illness combined with addiction. And what caught my eye here is a highly specific, unique piece of text found only under this section.
Yeah, this breaks the usual pattern.
It totally breaks the knowledge treatment courses triad. Instead, the text says, Viden om dobbeldiagnose, behandling of dobbeldiagnose, and then Fåhjelp om recovery mentor, mens doer behandling.
Which means get help from a recovery mentor while you are in treatment.
Yes, this is a profound inclusion, but why? Why don't they offer a recovery mentor for OCD or PTSD? Why specifically for someone who has, say, severe depression and an alcohol addiction?
Because the medical establishment has learned, frankly, through decades of catastrophic failure, that treating simultaneous mental illness and substance use requires an entirely different operational framework.
Catastrophic failure.
Oh, absolutely.
Yeah.
To understand why the mentor is necessary, we have to look at the biology of self-medication and the failure of siloed medicine.
What do you mean by siloed medicine?
Historically, addiction clinics and psychiatric wards were completely separate entities. And worse, they were often antagonistic towards each other.
Really? Antagonistic?
Yeah. If a patient with severe social anxiety and alcohol use disorder went to the psychiatric ward, the doctors would say, your liver enzymes are a mess and alcohol is a depressant. We can't safely prescribe you psychiatric medication or do therapy until you are completely sober. Go to rehab.
And so they go to rehab.
And when they go to rehab, the addiction counselors would say, you keep relapsing because your untreated social anxiety is unbearable. You need psychiatric stabilization before our addiction program will work. Go back to the psych ward.
Wow. So it was a lethal catch-22. The patient just falls into the abyss between the two buildings.
Exactly.
But how does dual diagnosis actually work biologically? Are they just two separate diseases happening at once?
No, they're completely intertwined. Let's stick with the anxiety and alcohol example. When a person with severe anxiety drinks alcohol, it binds to the GABA receptors in the brain.
GABA, that's a neurotransmitter, right?
Right. GABA is an inhibitory neurotransmitter. It slows things down. The alcohol artificially provides the chemical relief the anxious brain is absolutely desperate for.
Okay, so it works.
It works too well, but
Right.
the brain adapts. It downregulates its own natural GABA production and spikes glutamate, which is an excitatory neurotransmitter, to counter the effects of the alcohol.
Oh, I see where this is going. So when the alcohol wears off,
The brain is flooded with excitatory chemicals.
making the anxiety 10 times worse than it was originally.
Exactly. It's a neurobiological trap. You literally cannot treat the anxiety without addressing the neurochemistry of the addiction. And you cannot treat the addiction without addressing the agonizing psychological distress that drove the patient to self-medicate in the first place.
They lock together.
Yes. The formal category of dual diagnosis is the system finally admitting that these must be treated simultaneously under one roof.
Okay, I understand the necessity of the unified clinical approach, but where does the recovery mentor come in? Why not just say, get help from a dual diagnosis specialized doctor?
Because clinical expertise is not the same thing as credibility.
Credibility.
Think about it. When you are withdrawing from opioids while simultaneously navigating a severe bipolar depressive crash, a doctor in a white coat with a clipboard feels alien.
Right, they're just an authority figure.
Exactly. And for many people with severe substance use disorders, authority figures have historically been a source of trauma, incarceration, or intense judgment. So the white coat actually triggers a stress response. They put their guard up.
So a recovery mentor.
The recovery mentor is a peer. It is someone with lived experience who has survived the exact neurobiological nightmare the patient is currently in.
Wow.
When a mentor looks at a patient and says, I know exactly how much your bones ache right now, and I know the depression is telling you that you are worthless, but I survived it, and here is how we get through the next hour. Well, that completely bypasses the clinical authority resistance.
It's mirroring. The patient sees themselves, but a version of themselves that actually survived.
Mirror neurons are a big part of it, yes. It builds instant trust. The fact that the capital region of Denmark formally integrates and advertises recovery mentors right on the front page of their medical portal means they have institutionalized peer support.
They are financing and legitimizing lived experience as a vital medical intervention right alongside pharmacology and cognitive behavioral therapy.
As a humbling admission by the medical system that science and doctors just aren't enough sometimes. You need community to actually pull someone out of the fire.
That is incredible. Well, this idea that context matters, that a patient isn't just a textbook diagnosis, leads us directly into the most fascinating part of this entire website.
The Matrix.
Yes, I was honestly shocked to see a healthcare system organize itself this way. It's a category called Særlige målgrupper in Psychiatrien, på tværs of diagnoser, which translates to special target groups in psychiatry across diagnoses.
This is where we see the transition from a purely biological model of medicine to a true biopsychosocial model.
Let me throw an analogy at you. Think of diagnosing and treating mental health like trying to solve a Rubik's Cube.
Okay, I'm with you.
The main diagnoses we talked about earlier, depression, PTSD, ADHD, those are the solid colors on the faces of the cube. But this special target group section, these are the axes that you twist.
Ah, I like that.
It fundamentally changes how all the colors interact with each other. A red square behaves differently depending on how you twist the underlying structure.
The diagnosis is the illness, but the demographic is the host. And the host dictates the treatment just as much as the illness does.
Let's systematically go through these demographics because the specific ones they highlight are incredibly revealing. The very first one listed is Døve Psykiatrien, meaning deaf psychiatry.
Right.
Now, my initial, probably naive thought is, if a deaf person has depression and they need therapy, you just hire a sign language interpreter to sit in the room with the standard therapist. Why does deafness require an entirely separate psychiatric division?
That is the standard assumption, and it completely fails to understand both the linguistics of sign language and the mechanics of trauma therapy.
Really? How so?
Let's talk about the interpreter first. Psychotherapy, particularly for severe trauma or psychosis, relies heavily on nuance, microexpressions, pacing, and the therapeutic alliance between the patient and the provider.
Right, building trust is the whole foundation.
When you introduce a third person, an interpreter, into that intimately vulnerable space, you completely fracture the dynamic. The patient is no longer connecting with the therapist, they're connecting with the interpreter.
I never thought about that.
Furthermore, sign languages are not just spoken languages translated onto the hands. They possess entirely different grammatical structures, spatial relationships, and idioms.
But how does that impact psychiatric symptoms?
Profoundly. Let's take psychosis again. If a hearing person experiences auditory hallucinations, they hear voices. If a profoundly deaf person experiences hallucinations, they might see floating, signing hands, or they might physically feel a sensation of communication.
Oh, wow. That's a completely different sensory experience.
It is. A standard hearing psychiatrist, relying on an interpreter, might completely misinterpret those somatic or visual symptoms. Moreover, trauma is often encoded in the brain, visually and spatially, for deaf individuals.
So a standard clinic just isn't equipped.
Relegating them to a standard clinic with a translator is frankly clinical negligence. A dedicated deaf psychiatry unit means having practitioners who understand the specific neurological, cultural, and linguistic realities of how a deaf brain processes psychological distress.
That completely flips how I thought about it. The medium of therapy is just as important as the diagnosis. Okay, the next target group on the matrix is gravitet, Fordreskab og psykisk sygdom pregnancy, parenthood, and mental illness.
The pharmacological and ethical stakes here are astronomical.
Because you aren't just treating one patient anymore, you're treating the mother, but whatever you give the mother goes straight to the fetus.
Exactly. The fetal blood-brain barrier is highly permeable. Almost all psychiatric medications, SSRIs, mood stabilizers like lithium, antipsychotics, they all cross the placenta. So the psychiatrist is constantly weighing terrifying risks.
What's the calculation? I mean, surely the safest thing for the baby is for the mother to take zero medication, right? Just tough it out.
That is a massive misconception, and it's exactly why a specialized unit is required. Let's say a pregnant woman has severe bipolar disorder. If you take her off her mood stabilizers, the risk of her experiencing a severe manic episode or a suicidal depressive crash during pregnancy is extremely high.
Which obviously endangers both of them.
Yes. A severe maternal stress response floods the fetal environment with cortisol, which has documented long-term neurodevelopmental impacts on the child.
So it's a lose-lose situation.
It's a balance. Do you risk the potential teratogenic effects, the birth defects of the medication? Or do you risk the catastrophic physiological and behavioral effects of an untreated severe psychiatric episode?
That is an impossible choice for a standard general practitioner to make.
It requires immense specialization. They have to monitor fetal cardiac development if the mother is on lithium. They have to monitor the neonate for withdrawal symptoms or serotonin syndrome after birth if the mother is on high-dose SSRIs.
And it doesn't even end at birth, does it? The portal specifically mentions parenthood.
Right, the postpartum period.
Yeah.
The hormonal crash postpartum is the most massive endocrine shift a human body can experience. The sudden drop in estrogen and progesterone can trigger postpartum psychosis, which is a lethal psychiatric emergency. A mother experiencing delusions regarding her infant requires an immediate, drastically different clinical environment than a standard depression clinic can provide. By carving this out as a transdiagnostic category, the system ensures the treatment is viewed entirely through the lens of maternal-fetal biology.
It's intense. Okay, let's twist the Rubik's Cube again. Red psychiatry, forensic psychiatry, the intersection of the medical system and the justice system. I imagine the friction here is just massive.
It is the only branch of psychiatry where the primary goal is not solely the well-being of the patient.
What do you mean? What's the other goal?
Public safety. In a standard psychiatric setting, the ethical mandate is entirely centered on the patient's recovery and confidentiality. In forensic psychiatry, which deals with individuals who have committed crimes but are deemed severely mentally ill, the doctors have a dual mandate.
They are treating the patient, yes, but they are also acting as agents of the state.
Exactly. They're constantly assessing the patient's ongoing risk to society.
But that completely destroys the concept of a safe, confidential therapeutic space. I mean, how do you get a patient to open up about their violent delusions when they know the doctor is legally obligated to report those delusions to a parole board or a judge that will just keep them locked up?
It is an incredibly difficult therapeutic tightrope.
Hmm.
The legal statutes dictate the timeline for release, the types of interventions allowed, and the security protocols. The doctors are often called to testify against their own patient's desire for freedom.
It sounds like a paradox.
It is. A forensic ward is a locked facility. It feels like a hybrid of a hospital and a prison. The inclusion of this in the cross-diagnostic menu routes families into a system equipped to handle both the severe psychopathology, often severe schizophrenia or extreme personality disorders, and the labyrinth of the legal system.
The context just totally overrides the standard treatment protocols. Okay, the final demographic in this specific matrix is elder psychiatry, geriatric psychiatry. Now, I understand the elderly have different social issues, like isolation or losing a spouse. But biologically speaking, isn't a 75-year-old brain's depression the same as a 30-year-old brain's depression?
Biologically, a 75-year-old body is an entirely different pharmacological landscape. This requires a deep understanding of pharmacokinetics, which is how the body moves drugs through its systems.
Because their organs are older.
Precisely. Let's look at the liver. The liver uses specific enzymes, particularly the cytochrome P450 system, to metabolize psychiatric drugs. As we age, hepatic blood flow decreases, and these enzymes just become less efficient.
Okay.
The kidneys also slow down, reducing the clearance rate of medications.
So if you give an 80-year-old the standard adult dose of an anti-anxiety pill,
The drug stays in their bloodstream much longer and at much higher concentrations. It builds up. A dose that mildly relaxes a 30-year-old can cause profound sedation, severe confusion, and a loss of motor control in an 80-year-old.
and in the elderly, a fall caused by dizziness from overmedication can lead to a broken hip, which drastically increases mortality rates.
Exactly. So a standard psychiatrist might accidentally over-medicate them just by following standard guidelines. And the diagnostic overlap is just as treacherous.
What do you mean by diagnostic overlap?
Well, if an elderly patient presents with severe apathy, memory loss, and social withdrawal, a standard practitioner might diagnose severe depression. But a geriatric psychiatrist knows about pseudo-dementia, where depression mimics cognitive decline.
Oh, wow.
Or, conversely, they know that these mood changes might actually be the very first prodromal symptoms of Alzheimer's disease or vascular dementia.
So you really need a specialist who can untangle the psychological from the neurodegenerative.
Yes. The phrase "post-fares of diagnosis or across diagnoses" is a testament to the biopsychosocial model. A pregnant woman, a deaf teenager, and an 80-year-old man might all technically carry the exact same ICD-10 label of severe depressive episode.
But treating them identically would be malpractice.
Exactly. This website architecture acknowledges that. It proves the system sees the context, not just the code. And again, this is a brilliant workaround while they struggle with the missing ICD-11 implementation. They're adding the necessary dimensions through demographics rather than overhauling the base labels.
I see the illness, but I also see the host. It's brilliant. But as I was looking through this list of special target groups, I noticed something that broke the pattern.
The anomalies.
Yeah. Deaf, pregnant, forensic, elderly. Those are clear demographics. But there are two entries sandwiched in this list that stand out as complete anomalies.
Items that, structurally speaking, don't belong in a list of demographic identities.
Right. So let's look at the first one. Right there in the list of special target groups is the word self-scade, which translates to self-harm. Now, wait a minute. You can't be a self-harm. It's not a demographic.
No, it's not.
It's an action or a symptom. So why is it listed as a transdiagnostic target group instead of just being listed under the conditions that actually cause it, like depression or borderline personality disorder?
Because of the acute biological reality of the symptom. This is where triage overrides taxonomy. By pulling self-harm out of the specific disease categories and putting it on the main menu, the system actively refuses to pigeonhole the behavior.
Meaning they don't want people to think it only happens in specific disorders.
Exactly. Historically, self-harm cutting, burning, severe blunt trauma was rigidly associated almost exclusively with borderline personality disorder. But clinical data shows it spans the entire psychiatric spectrum.
So anyone could experience it.
Yes. A teenager with undiagnosed autism experiencing overwhelming sensory input might self-harm. A patient with severe OCD might do it as a compulsion. Someone in a severe mixed bipolar episode might do it.
But why do they do it? I mean, mechanically, why does inflicting physical pain alleviate psychological distress? That seems completely counterintuitive to basic survival.
It comes down to a mechanism called pain offset relief.
Pain offset relief.
Yeah. When you inflict acute tissue damage, the body perceives a massive physical threat. The brain immediately responds by releasing endogenous opioids endorphins into the central nervous system to blunt the physical pain so you can survive the perceived attack.
So it's a massive biological rush of painkillers.
Yes. And those endogenous opioids don't just numb physical pain. They provide a rapid, profound wave of emotional numbing and regulation.
Wow.
For a patient experiencing intolerable, screaming psychological agony, self-harm is a highly effective, albeit deeply destructive biological hack to force their brain to release soothing chemicals.
So if I'm a parent and I discover my teenager is self-harming, I am in a state of absolute panic.
And that's exactly why it sits on the main menu. If you are in a crisis, you don't have time to sit down and analyze whether your teenager's self-harm is rooted in trauma or autism or an eating disorder.
You need to stop the bleeding, literally and metaphorically.
This system prioritizes immediate harm reduction over clinical categorization. It acts as a giant red emergency button. It says, "We will figure out the underlying diagnosis later. Right now, click here to get the crisis protocols."
It's the ultimate pragmatic design. You treat the hemorrhage before you figure out what caused the wound. Okay, now let's look at the second anomaly, and this one sent me down a massive rabbit hole.
The historical term.
Yes. The category reads, Udviklingsshemning, then in parentheses, oligophrenie, og psykisk sykdom. This translates to developmental disability, oligophrenia, and mental illness. It's that word in the parentheses that really got me, oligophrenie.
It is a fascinating linguistic fossil defined on a modern regional healthcare portal.
It really is. I looked into the etymology. Oligophrenia comes from Greek. Oligo means few or little, and phrenia means mind, literally small mind or decreased mental capacity.
Right.
This term is incredibly old. It was heavily used in the late 19th and early 20th centuries, and historically it's loaded with incredibly dark baggage institutionalization, the eugenics movement, forced sterilizations.
This is a very heavy word.
Almost all modern psychological manuals have completely phased it out in favor of intellectual disability or developmental disorder. So my question is, why on earth would a forward-thinking 21st century Danish healthcare portal deliberately include an antiquated, historically heavy term right on its front page?
This goes back to the tension between the pristine, evolving medical taxonomy and the messy reality of the humans who actually use the system. Medicine loves to update its vocabulary. As our clinical understanding and our societal empathy grow, we constantly discard older terms.
Right. Words like idiot, imbecile, and moron were actually official clinical diagnostic categories before they drifted into the colloquial language as playground insults. The medical field had to invent new terms to outrun the stigma.
Exactly. The taxonomy must evolve. However, what happens to the patients who are diagnosed under the old regimes? Consider a 75-year-old mother who has been the primary caregiver for her 50-year-old son his entire life.
Okay.
When he was diagnosed in the 1970s or early 80s, his official medical paperwork, the documents that grant him state support, might have literally said oligophrenie.
Oh, I see.
For 40 years, that is the word that mother has used to navigate the medical bureaucracy. If she goes to this brand new, modern digital portal looking for crisis support for her aging son, and she only sees modern terms like neurodevelopmental disorder, she might not recognize it.
She might assume that the specific clinic that treats her son has been shut down, or that the resources simply aren't there anymore.
She gets locked out of the system because the password's changed, essentially.
That is heartbreaking.
Precisely. By including oligophrenie in parentheses, the portal is sacrificing absolute modern political correctness for the sake of accessibility. It acts as a linguistic bridge. It ensures that an aging, highly vulnerable demographic of caregivers doesn't fall through the digital cracks.
It's essentially SEO, search engine optimization, for the elderly and the historically diagnosed. They put the old keyword in there so the search query still works.
Exactly.
That is a deeply compassionate use of user interface design. It acknowledges that the medical establishment leaves a long tail of patients behind every time it updates its dictionary.
It is the reality of healthcare as a continuous generational process. Which actually brings us to the final element of these screenshots we need to discuss. Because for all the polish and careful thought put into this architecture, there is one section that completely shatters the illusion of a finished, perfect system.
You're talking about the section on spice for ulcer or eating disorders.
Yes.
So when you look at ADHD or depression or anxiety, you get that neat triad we dissected earlier: knowledge, treatment, courses. But when you look under the heading for eating disorders, all those links are gone.
Just gone.
Instead, there is just a single sentence. It states, Den ene spice for ulcer og behandling of spice for ulcer I region hovedstadens psychiatry under udarbedels.
Which means this page on eating disorders and treatment of eating disorders in the Capital Region Psychiatry is under development.
I have to admit, seeing a major medical category essentially wearing a yellow under construction hard hat on a live regional health portal is incredibly jarring. Eating disorders, anorexia nervosa, bulimia, binge eating disorder, these are not niche issues.
Not at all.
Anorexia has one of the highest mortality rates of any psychiatric illness due to cardiac complications and suicide. Why on earth isn't the page finished? Is the system just failing them?
It's jarring because we expect medical authorities to be omniscient, monolithic entities that have everything figured out. But the reality is that psychiatry is a rapidly evolving science. The underdevelopment tag, especially regarding eating disorders, points to massive structural shifts currently happening behind the scenes.
What kind of shifts?
A few things. First, the clinical protocols for treating severe eating disorders are changing. Historically, treatment was heavily focused on purely psychiatric interventions or, frankly, forced refeeding.
Right.
Modern protocols require deeply integrated teams of endocrinologists, dietitians, cardiologists, and specialized psychotherapists. Integrating those different medical silos on a regional level is an administrative nightmare.
So they might literally be physically reorganizing the clinics?
Very likely. Furthermore, the diagnostic landscape of eating disorders is expanding rapidly. The system is dealing with an explosion of diagnoses like ARFID, avoidant restrictive food intake disorder, which often intersects heavily with autism and sensory processing issues, completely distinct from the body image issues associated with classic anorexia.
And this ties back to the ICD-11 transition we talked about at the beginning, doesn't it? The missing ICD-11 implementation rears its head again.
It ties everything together perfectly. The ICD-11 significantly updates the criteria and categorization of eating disorders to better reflect clinical reality. If the Capital Region is updating their treatment protocols to align with new international guidelines, they literally have to rewrite everything.
The patient education materials, the treatment pathways, the course curriculums.
All of it. So rather than leaving up a page with outdated ICD-10 information or old clinic contact numbers that might lead a vulnerable patient to a dead end, they chose to honestly put up a barricade. We are currently rebuilding this.
It destroys the illusion that medicine is a finished product. It demystifies the healthcare system, showing it as a living, breathing entity that must constantly adapt to new evidence, new funding structures, and new international manuals like the ICD-11.
As frustrating as it might be for a user in the moment, transparency about what is currently broken or being rebuilt is ultimately what builds long-term trust in a medical institution.
It's an admission of humanity at an institutional level. Well, we are almost out of time, so let's summarize the massive amount of ground we've covered today. We started with a very simple premise, that 3 screenshots of a digital menu could reveal the entire architectural blueprint and underlying philosophy of a psychiatric care system.
And we found a system navigating immense complexity.
We really did. We saw a system that attempts to empower patients by mandating psychoeducation, putting knowledge before treatment to neurologically down-regulate trauma. We saw how it handles the breakdown of neat diagnostic categories, grouping the psychotic spectrum together to reduce cognitive load.
And institutionalizing peer recovery mentors because they recognized that doctors alone cannot cure dual diagnosis addiction.
We saw the biopsychosocial model in action through the cross-diagnostic matrix, proving that treating a pregnant woman, a deaf individual, or an elderly patient requires completely different clinical environments, even if they share the exact same diagnosis.
We dissected the pragmatic triage of elevating self-harm to the main menu to bypass diagnostic bottlenecks. We explored the deep compassion of leaving historical linguistic fossils like oligophreny in the code so aging caregivers don't lose their access.
And finally, we saw a system bracing for the incoming wave of the ICD-11, leaving sections under development rather than presenting outdated science.
If I were to synthesize the ultimate goal of all these microscopic decisions, every layout choice, every specific phrasing, it all comes down to the management of friction.
Friction between the patient and the help they need.
Yes. When a human being is in a state of psychiatric emergency, their cognitive resources are entirely depleted. The brain is on fire. If the healthcare system is a rigid labyrinth of complex medical taxonomy, that friction is not just annoying, it is a literal barrier to survival.
Wow.
By designing a system that anticipates the messy realities of lived experience,
Yep.
that understands pharmacology and demographics, and that speaks the language of the user, even if that language is technically outdated, you reduce that friction. You make the path to intervention smoother. And in mental health care, a smoother path saves lives.
A smoother path saves lives. That is the perfect encapsulation. It's not just web design, it's clinical empathy engineered into a digital space.
Exactly.
As we wrap up this deep dive, I want to leave you, our listener, with a final thought to mull over. We spent a lot of time today talking about that Rubik's Cube, the cross-diagnostic matrix where the medical label intersects with the specific context of a person's life, the tension between the disease and the host.
The most important tension.
Think about your own life right now. If you were forced to map out your own physical or mental well-being today, how would you intuitively navigate it? Would you define your current state purely by the medical labels, the chronic back pain, the localized anxiety, the specific issues you carry?
Or would you categorize your needs by the context of your life right now?
Exactly. Are you navigating a massive career transition? Are you dealing with the aging and decline of your own parents? Are you a new parent yourself, sleep deprived and flooded with new hormones? Because as we've learned from dissecting this portal, the medical label might tell you what the issue is, but it is the context of your life that dictates how you actually heal. Thank you for joining us on this deep dive. We'll see you next time.